Hello and welcome to another confined edition of the France 24 debate. We're asking the question of just after 3 months, how little we know about COVID-19. For this, I want to welcome at this point, joining us from Ann Arbor, Michigan, is Dr. Arnold Monto, epidemiologist and professor of global public health at the University of Michigan. And from the Hôpital Saint-Antoine Hospital in Paris, Dr. Karine Lacombe, who heads the infectious diseases department there. Welcome to both of you, and thank you so much for taking the time out to speak with our viewers.
Hello, thank you for inviting us.
Let me begin with you, Dr. Lacombe. What's the situation at your hospital this Tuesday?
Well, so the situation is a bit complex. We've got a lot of patients in the medicine wards and in ICU as well. It's almost full. Fortunately, a lot of people are going out of hospital, not completely cured, but almost cured. So that's very good news. And a few of them from the medicine ward go to ICU, and that's very unfortunate. We've got a lot of people dying as well. A lot less though than people going outside of the hospital. So there is some hope, and that's very fortunate. We are starting clinical trials, so offering new drugs to the patients, and hopefully those drugs will work. So the situation is very tense though, and healthcare professionals are starting to be a bit tired, but we are on board, definitely.
I can imagine. Before I ask you about those clinical trials, the question everyone's asking is confinement. Here in France, it's been exactly 2 weeks. When will we see that peak in the number of cases and the number of deaths?
So we are eventually starting to see a bit of the effect of confinement. Because the curve, which was going up and up and up of death and admission to hospital, it starts to look like it's getting a little less steep. So we think that that's what we were expecting, after 2 weeks of confinement, that we may see an effect on the steepness of the curve. And it looks like it's a little less steep than it used to be. So probably this week, we hope to have reached a plateau, and then we'll see how long this plateau will be, and then if we can down curve, really act on putting the curve down.
Dr. Monto, before I ask you about the situation in the United States, your reaction, again, this is partly an issue of arithmetic, right, when you're talking about the spread of a disease. Here in France, the number of deaths doubles every 3 days. The number of new cases doubles every 4 days. Is that normal?
There's nothing normal about this. And the doubling will depend on how much transmission is taking place. And I think the transmission for this virus is particularly tricky because it is very different in different areas. Look at what happened in Italy, where it started in an area of small cities, not a major metropolitan area, and stayed confined almost completely in the Lombardy and neighboring areas, never really moved into southern Italy, even though people traveled there from northern Italy. What is clear is that social distancing, closing things down, does have an effect. And it takes a while. And deaths actually are a lagging indicator because the person has to be infected, has to develop the disease, then has to go through whatever care he or she is getting in the hospital before dying. So we will see reductions in deaths long after we see reduction in transmission. And our testing is not being done well enough to really be able to look at number of cases with any kind.
Yeah, we're going to talk about that testing issue in a minute.
Okay.
I just want to show images of Well, that affect me personally, being born in New York City, to see that hospital ship come into town, and also a field hospital set up in Central Park across from Mount Sinai Hospital on a field where, when I was in high school, I sometimes played soccer on. I know where you are, Dr. Monto. It's even more dramatic. We can show images of that were posted to Snapchat by a nurse in the Detroit area.
So today was the first day that I've worked since our unit was designated the second COVID ICU in my hospital. And I don't know what the fuck just happened for the past 13 hours. Honestly, guys, it felt like I was working in a war zone. Completely isolated from my team members, limited resources, limited supplies, limited responses from physicians because they're just as overwhelmed as we are dealing with a ton of other stuff. So basically I just spent the last 13 hours like treating 2 critically ill COVID patients on the vent basically by myself. And this is my new normal for the next however many months that it takes for this virus to die down. So like I'm already breaking, so for fuck's sake, people, please take this seriously. This is so bad.
Dramatic statement there, Arnold Monto, from that Detroit area hospital. I know it's one of those epicenters in the United States. You hear that nurse there expecting this to be her new normal for months. Your reaction?
I don't think it's going to be for months. I think we really have to admire the work of the caregivers who are spending long hours, often with not the best personal protective equipment, and then questioning about going home to their families when they know they are at risk, increased risk of developing infection. I think that we are already seeing in some places the effect of social distancing. I think in Michigan, we really put the state into emergency situation at the beginning of March. We've been closed down for almost 2 weeks now. And I think we're going to be able to see an effect fairly soon. Again, the deaths are a lagging indicator. Patients are going to be there on vents for quite some time until they either get better or don't. And it is tough because, again, with an epicenter, everything is being concentrated in narrow geographic areas. And for those who are there, it is very difficult.
And Paris is one of those epicenters, Karine Lacombe. How's morale among staff?
It's not too bad because we have been getting prepared for a few weeks now, and so we have increased the number of healthcare professionals working in the hospitals. We have opened a lot of rooms for medical needs and ICUs as well, and we are upgrading every day the ICUs and opening more and more rooms. So I'd say that because we've been prepared. Because of the epidemic in the east of France, which the virus has hit the east of France before hitting Paris. So we've seen what was going on there, what was going on initially. So we have like 2 weeks to get prepared to get the wave, to get the tsunami. And even if you are not completely prepared, because we are still opening ICUs and ICUs, we of course we are kind of overwhelmed, but I have to say that the staff is really hard to work and very strongly linked together, and so we are not doing too bad, I have to say.
Dr. Monto, I spoke to the head of a Paris area hospital on Monday, who used exactly the same word you just heard from Dr. Lacombe, which is that thankfully, he says, we had those 2 weeks to learn lessons from what was happening in Lombardy. And that means that we were able to get at least a little bit ahead of the curve, even though the worst of the wave is still to come. Is it the same in the United States?
I don't think it is because we are much less centralized than the situation in France and in Europe. We have many different hospital systems. There is some cooperation, some antagonism because in some ways they compete for patients in the normal situation, and it is a larger ask to get them to cooperate. That is happening. We do have plans for overflow going from full hospitals to less full hospitals, but really there are some structural issues that we have in dealing with this kind of a problem that would not exist in an issue in a country like France.
We can show, this is a graph that courtesy of the Financial Times, and if you look at it, you'll see that obviously Lombardy is off the charts. So is Catalonia, the Madrid area. In the US, the New York City area, and where you are in Michigan is not that far off, by the way, from the way the curve is headed in New York. You were saying earlier, Dr. Monto, how it's so hard to understand how this virus works. What does that chart tell you?
Well, that chart tells us that in epicenters, this takes place. But we do not really understand why some places become epicenters and others do not. For example, the place that first experienced the coronavirus in the United States, Seattle, apparently is responding. They were in bad shape for a while, but they really did not achieve the bad distinction of being totally overwhelmed, as seemed to be the case in New York. And in New York, it seems to be in some areas and not others as well. So this is very focal. And that's one of the reasons why being able to collaborate in terms of the response is very important.
Dr. Lacombe, what conclusions do you draw?
Then we are in it now, so we have to face it. We have to gather all the healthcare professionals. We have to gather the political will to fight against the virus. I'm sure that we will win. I'm sure that unfortunately we will lose a lot of our citizens, and mainly the most fragile, the oldest, and that's very sad. But I hope that we will get out of this crisis even stronger as a nation than before. And I know that at that time there are many controversies regarding what has been done or not done before the epidemic, controversies about treatment, access to treatment, etc., the way research is made, etc., etc. But at that point, I think that it's very important to gather all the people who can fight the virus and in order to win the battle.
We're showing images of Italy where they are beginning to see a peak, or at least they're cautiously optimistic that they're beginning to see a peak, perhaps. Dr. Lacombe, there's the issue because it's now been more than a month, right? On the one hand of why it got so bad in Lombardy. Again, we don't know. That's a mystery, as was described by both you and Dr. Monto. But also, testing. Why is it that we haven't been able yet to roll out mass testing that works?
Well, regarding the situation in France, unfortunately, we had no the reactants for the testing. So we had the PCR, we had the virus, but we had no reactants because the reactants were manufactured in the United States and in China. And then obviously it was very difficult to get anything from China. And then the United States kept the reactant for themselves. So at some point, we had a lot of trouble to find everything to make the test. The situation is changing. New tests have been developed, rapid tests, antibody tests on top of PCR, and we are starting to get those tests. But obviously at the beginning, right at the beginning of the epidemic, we did not have enough tests to test everybody when the epidemic was not completely aware.
You say you're starting to get those tests.
Yes, we do.
When will those tests be available en masse? And I mean, basically, right, to reopen the country, we're going to need to be able to test everybody, right?
Yes, well, there are two kinds of tests. There are the molecular tests to see if the patient has an acute infection, and then there is the antibody test to look at the seroprevalence of infection and to make the difference between people who have encountered the virus and people who are naive to the virus. And probably when we will do the deconfinement, it will be very important to know who is immunized and who is not immunized. And the ones who are immunized will probably be the first ones to get out of confinement. And the ones who have not been immunized, then probably they will get back to work with a mask. But we don't really know right now the policy that we will apply for the confinement.
We know that the head of the Red Bull Formula One racing team in Austria, the head of the Red Bull Formula One racing team in Austria says he'd like to get all of his drivers infected so that way they can be ready for the Formula One season. Is that the right mentality to be having?
That's terrible. I think that's terrible because it's exactly what happened at the beginning in the UK, where the Prime Minister said, "Okay, just let the virus come to the country, and then at least everybody will be immunized." But then you have to pay a very heavy tribute to death, because a lot of people will get infected right at the same time, and they might have complications and just die. So it's very difficult to have that kind of policy when you have no treatment, no vaccine. So I would really not advise to do that.
Dr. Arnold Monto, you were on the front lines in dealing with the SARS outbreak in 2002, 2003. Can we expect, should we just be fatalistic about it and say to ourselves, well, over a period of time, 70% of the planet is going to get this in one form or another?
Absolutely not. SARS taught us one thing, and that is to expect the unexpected, and sometimes the unexpected is good news, because we all predicted that the SARS virus would not go away, and it did completely. We still don't understand, because everybody wasn't infected. And I would submit that doing seroprevalence is not going to be a great help here in opening up, because I don't know that large a percent of the overall population is being infected, especially with the focal nature of this infection, hitting some places very hard and hitting other places much less severely. And I don't know really that you can say that because one place has become like Italy, every place is going to become like Italy. And that's the kind of prediction we hear most of the time. I think what we are going to need the rapid tests for, and this would be the point of care tests, which I hope don't have a lot of false negatives, which has been the problem with some previous point of care tests, is we're going to be able to show that the virus is going down in transmission. And then we'll have the difficult job of trying to figure out how to open when the virus is going down. I think we're going to see much less transmission as the weather warms up. The big question is whether it's going to come back in the autumn when people go back to schools and when we really try to start things going. It didn't with SARS, but was SARS a one-off, or is it going to behave like flu? Because we know with flu it would come back.
And so that brings us back to the question, brings up lots of questions. The first one being, which we talked about a minute ago with Dr. Lacombe, which is mass testing. How do you roll it out as fast as possible?
Well, I don't know that we need mass testing. We need targeted testing, trying to answer some questions. And the question, right now we need it for diagnostic purposes. We also need it for contact tracing if we are able to contact trace, because in many places now, shutting everything down takes the place of contact tracing. We just assume that everybody could be infected. But when we open up, that's when we really are going to need it to track what's going on and whether we're opening too fast or not.
Dr. Lacombe, you saying that part of your effort is obviously diagnosis. Another part of your effort is treatment. What have you learned in the last couple of weeks?
So that's when you do bad studies, you have bad results. So we are trying to set up clinical trials that are following, the good the good clinical practices, and it's very difficult when you are in a context where everybody is so anxious to find a treatment, and everybody is very, very um, has a lot of fear about what's going on. So right now, a lot of treatment are coming up for clinical trials. Some treatment are antivirals. Some other are modulating immunity. Some others are specialized for the acute respiratory insufficiency. So I think that it has triggered a lot of clinical research, and I hope that in a few weeks, in a few days, we all know which treatment is better than the other, and regarding efficacy, but also safety.
Bad tests, bad. You're making a dig at the tests out of Marseille, Dr. Raoult's, where he's been administering as a clinical test hydrochloroquine as part of a cocktail of treatments.
Yeah, well, I hope that chloroquine will be an effective treatment. I just would like us to give us the best opportunity to prove that it's a very efficient treatment, and that efficiency is better, and there is no side effects. And so it takes a bit of time, and hopefully we'll have strong results in the coming days from other trials with a better methodology to really find if this treatment is very efficient, maybe in very early disease, and maybe not when it's too late, and then when it's too late, that we may have other drugs. And so we need to have a lot of clarity regarding that in order to best prescribe for the patients.
How fast? How fast can we know?
It's difficult to say. Hopefully, I don't know, in a few days, 1 or 2 weeks. That's what we are targeting for.
Arnold Monto, you agree?
It's very difficult. I reviewed some of the results in Beijing during the 2003 pandemic. I found it impossible since there was nothing done systematically, to draw conclusions, because when a patient is very sick, everything is thrown at that patient in a non-systematic way. So you have to do appropriate clinical trials. It doesn't have to involve a placebo, but it needs to have some kind of systematic comparison. Now, the other thing that I've heard is that they're looking at chloroquine or hydroxychloroquine as prophylaxis. I don't think we're going to be able to do prophylaxis studies right now in the face of this outbreak without the sufficient number of clinical trials. I've worked extensively on prophylactic studies and also some treatment studies with oseltamivir, the flu antiviral, and they're difficult to conduct. And if you don't conduct them just right, there are people who are going to be jumping all over you, telling you how badly you did the test.
This is the thing, whether tests are effective, whether tests are accurate. Even now, with what we're still talking about whether or not the actual casualty toll is accurate, well, with each country having a different method of counting those who are ill or who've died. Here in France, for instance, they're not counting people in old age homes, whereas they are.
They are starting now. They've been starting yesterday. So we have not counted them for the few past weeks, but they've been starting yesterday. That's good.
When you look at the World Health Organization statistics, are they meaningless to you? Or is it like comparing apples and oranges? Or do you really get a sense of what it's like worldwide?
I think you're pretty right when you say that it's like counting oranges and apples. So go ahead, please.
Well, the WHO only is a group of member states, and they cannot make rules for each country. They can give advice and guidance, and therefore within a country, you can look at trends because you can assume that the system is the same over time. Comparisons between countries are very difficult.
The other issue is if we're going to see the light at the end of the tunnel, if we're going to begin to contemplate, as we started to talk about at the beginning of this discussion, the end of confinement, we also have to protect those that have to go out there, and those like yourselves, doctors and healthcare professionals who are on the front lines. One of the big issues has been masks. On Monday, I spoke with Eric Olander of the China-Africa Project.
What China is doing right now is they're trying to do what some people are calling flipping the script. They had a number of missteps early on, that cover-ups and lack of information, lack of transparency. We don't know for a fact if they're still doing that to this day. I mean, it's a black box in many respects. So we have to be cautious about everything that we see coming out of China in terms of data and whatnot. But what we do see is some action. And that action is that they are, in fact, getting things back to normal. I saw some data today that the port of Shanghai is starting to do a lot more export. That's a good sign. They're letting down some of the restrictions in Wuhan. That, too, is a good sign. Port activity in 8 of China's 10 largest ports is up in March. So those are real tangible things. So rather than the data, which is subject to interpretation and filtration and censorship, when we see actual action on the ground, that I think we have to take quite seriously. Now, in terms of global leadership, that's a different story. The Chinese are making a play because they do see an opportunity left by the United States that traditionally played that role. It's a high-risk, high-reward strategy, and both of those are very important in looking at this equation here. The Jack Ma, the former CEO of Alibaba, made this massive donation that was well received in Europe. Now he's sending materials to the United States and certainly to all 54 African countries. This was a big propaganda win, a big win for China, being able to deliver things and deliver badly needed resources to help fight COVID-19 that other countries simply either unable or unwilling to be able to provide. So that was a big win. Now what we're seeing, though, is that as mask manufacturing in China goes up dramatically now, so there's somewhere around 8,950 factories in China that are producing masks. The Chinese government is having a difficult time now ensuring quality. So one of the things that's starting to come out of Europe is the fact that some of the masks are apparently defective. Now, some of the masks, and Radio France International ran a story on their Chinese website, showed that some of the testing kits weren't being used properly in the Czech Republic. So there was a little bit of a misunderstanding there. They were reported to be defective. And in fact, RFI is reporting that there was really just a lack of training on the part of the Czech staff. I haven't seen any other reporting to confirm or validate that. But let's put the Czech side aside for now. What we are seeing in other parts of Europe is this risk. And the risk is that if healthcare workers in the United States in particular start to die because of defective and faulty masks, that is going to erupt into a huge problem for the Chinese.
Karine Lacombe, we're speaking on the day when France's president, Emmanuel Macron, has gone to the western city of Angers to visit a face mask producing factory. And we've heard his junior minister for European affairs warn China and Russia against the instrumentalization of humanitarian aid. Your thoughts on China and how they're handling it and this whole issue around face masks?
That's a very political question, and I'm not sure that I'm the best one to talk about that because I'm a scientist and a doctor. But of course, it might be quite easy to instrumentalize the question of masks because we are such in a big need of masks. And I know that President Macron has ordered like 1 trillion masks coming from China over the next month. So that might be, a tool for China to use, and I don't know, about the money, etc., etc. So I am a bit, how would you say, I'm a bit bitter about that story.
Why are you bitter?
Because it looks like, the virus is coming from China, and then we have not enough masks, and now that they have contained the epidemic, we are buying masks from China. So you feel like it's not fair. But I think that the first thing, very important, is that we have the mask, and then after the epidemic, it will be time to really look at the relationships between France and China and other countries, and in the world. You see.
Dr. Arnold Monto, your thoughts?
Well, I agree completely. I think part of this is trying to make people forget where the virus came from, and the fact that if we had known earlier how bad it was and how easily it was spreading within confined areas such as in the city of Wuhan, things might be different. On the other hand, if the masks are not defective, this clearly is a help. And we do want international cooperation, especially when one area has more supplies than another. Having them share is a good thing. So it's very mixed. And again, it becomes highly political. And I don't feel comfortable in diving into this kind of a political discussion because we have enough problems with our politicians engaging in these kinds of discussions.
All right, let's graduate from politics to philosophy then to finish. And Dr. Monto, has this brought out the best or the worst in humanity, this crisis?
I think it's bringing out the best because we really have not, and I'm sure the media looking for stories would be finding things where people were taking advantage, stealing masks, stealing things of this sort. We haven't really heard those stories. What we've heard are people sharing, people taking care of their neighbors, groups cheering the medical workers who are on the front lines. So I think this has brought out the best in people. I think on the bad side, we're going to see really structural problems with the economies as things open because parts of our economy are not that resilient. And I think we're going to need help to restructure the economy going forward for quite some time.
Yeah, especially in the United States, where your healthcare coverage is linked to whether or not you have a job very often.
Right, and also the hospitality industry. There are many, for example, restaurants that are what we would call mom and pop kind of operations, small restaurants, and we have a tipping structure in which the servers are dependent on getting money not from the restaurant itself but from the patrons. So these things are going to have to work their way through.
Dr. Colm, that clapping every night at 8 p.m., what's been the reaction of your colleagues and staff members?
Well, it's so supportive, A lot of us are leaving the hospital at about 8, spending like 12 hours per day at hospital. So when we leave, there is nobody in the streets because of confinement, obviously. So to see all those people in their windows clapping and singing and playing music, and it looks like we are, just carried on. It's just great. I used to cycle from the hospital to my home, and sometimes in the street I'm just by myself, and I hear all those people clapping in their hands, and it's so great. I feel like very warm inside, and it gives me and all my colleagues, the will to go on and do even better than usually.
We are eternally grateful for the work that you've done, that all of those who have to go out to the front lines, as it were, have been doing. I want to thank you so much for taking this time out, Dr. Karine Lacombe. I want to thank Dr. Monto for being with us from Ann Arbor in Michigan. The conversation continues and will continue on the hashtag F24Debate. Thank you so much for being with us. Do take care.
Thank you.
Thank you.
Bye.